Welcome to the Gerontological Society of America Annual Scientific Meeting, iSession. And the title of our session today is New Developments in the Advanced Care Planning in the Context of COVID-19. And we have a few housekeeping issues to discuss. First of all, it would be nice if you can introduce yourselves in the chat box and also use the chat box throughout the presentation to comment or ask questions. You can also flag technical issues there, and the GSA staff will try to help if they can. This conversation is being recorded and will be available at GSA's website. We will ask you to keep your video off if possible, and definitely the audio should be on mute because there are quite a few of us today until there is a time for discussion and you are given the voice. A question and answer session will be immediately follow the live presentation. My name is Panagiotis Sitouras, and you can see towards the bottom there of the list. And I am a professor emeritus in medicine at the School of Medicine at the University of Oklahoma. And my field was geriatrics, and my research had to do with endocrinology and aging. Today's iSession is part of a series by the GSA Program Publications and Productions Committee, work group, and future work and advances around the interdisciplinary topic. Without further delay, I will give the microphone to Brian Carpenter, who is going to be the chair of today's session. And here in that slide, you see the list of the other participants that they're going to be talking today. And after the short of formal presentations, we're going to have a discussion among the panel, and then we'll try to address many of your questions. Finally, I would like to thank one more person who was instrumental in organizing this whole session, and this is Judy Liu, the Vice President of the Gerontological Society of America, and I think without her, we'd have trouble getting this properly organized. Again, I'm turning it over to Dr. Brian Carpenter.
Thank you, Pan, and thanks to Judy and everyone at GSA. It's a pleasure to be back with the panelists that joined us together at GSA to talk about advanced care planning, and thanks to everybody who joined us today for today's conversation. Thanks, I can see some of you identifying yourself in the chat. That's great to introduce yourself to everyone. I hope we'll have a good discussion after a series of brief presentations that each of the original panelists plans to make, to give a little bit of a context in how the advanced care planning field has evolved since we got together at GSA a while ago, to give an update a little bit about some of the projects that we originally spoke about at GSA, and to hear from you about your own work and your perspective on how the field is shifting. Some of us do have some slides, and so I'm going to go ahead and kick things off. Can somebody nod if that looks okay to you?
Looks good.
Perfect, thank you. So my task is to provide a little bit of context in how some of the conversations have unfolded about advanced care planning. Over the last couple of years, there's really been a spirited debate in the literature about advanced care planning as a concept and its utility and effectiveness, and what we're actually doing with advanced care planning. And so for those of you who aren't in this area, like most of us on the panel are from day to day, I thought I'd just introduce you to a couple of important written works that have come out in the last couple of years. And this is one that really stimulated a great deal of conversation in the field. It showed up in 2021, written by three of the most prominent people who have been promoting palliative care and hospice care and advanced care planning over the last several years, prominent folks who really called into question in, for my mind, a kind of earth-shattering way, on the assumption that advanced care planning is actually beneficial, or at least in their review article, talking about what the research evidence suggests about the effectiveness of advanced care planning. And so just to give a thumbnail sketch of their critique, this is how they opened their article, by talking about the purpose of advanced care planning with the goal of ensuring that the care that people receive at the end of their life is concordant or agrees with their preferences and their values. When they can't express their own medical preferences, if they've done advanced care planning, presumably it leads the medical care team, family care partners to act in a way on their behalf that's consistent with the kind of care that they wish to have. And Morrison and colleagues really called into question whether the evidence suggested that advanced care planning actually does this. Does it actually lead to goal concordant care? And their review of the literature, in their eyes, says no, that advanced care planning does not appear to lead to goal concordant care. And when trying to explain why the research seems to suggest that we haven't accomplished this goal, they point to several different reasons why advanced care planning hasn't achieved this goal. And they all kind of fall under the main umbrella that in their eyes, there's a big gap between what we ask people to do when they are trying to articulate their future preferences by thinking about hypothetical medical scenarios that are in fact really, really different than what plays out in the clinical world. And they highlight as meaningful factors the reality that treatment choices are much more complex than a simple document can ever capture, that our preferences and values actually change over time and are fluid. So what you document at time A may be very different than what you think at time B. That when we're relying on surrogates to make decisions for patients, that they have a difficult time looking at the documents that we're having them fill out to extrapolate or understand how that document corresponds to current treatment decisions. That when you look at the documents themselves, that they're not always very clear or specific or precise about what people would want. And that advanced care planning tends to overlook the fact that there are structural factors, financial factors, social and cultural factors that also play a role in how treatment decisions are made. And those structural factors aren't really accounted for within the documents that we ask patients to fill out. So they leveled this pretty dramatic critique against advanced care planning, at least as it exists now, and kind of prodded the field to think about moving away from the traditional forms of advanced care planning. Now, as I said, this was an article that generated a lot of conversation in the field, and there were understandably some responses, some pretty hearty responses. This is one example of a response where a physician wrote back in to talk about some examples in their personal life about how advanced care planning had been useful. And this clinician talked about the value of the discussion, even if it doesn't necessarily result in more goal concordant care, that at least family members or people who are involved in the care decision process, and maybe even the clinicians, feel better about the choices that they make if they can reference a document that was originally written by the patient themselves. He articulates the idea that these are discussions that can kind of help lay the groundwork for future conversations. So having a conversation at one point in time then might make it a little bit easier for people to have conversations about these difficult issues in the future. And he also argues that the process of advanced care planning is valuable because it does prompt people to stop and pause and think and contemplate about what their preferences and values and goals really are. So he was making a case that we should not necessarily throw out the entire process of advanced care planning, that maybe some of the goals that we have for it are flawed in some ways, but that the process itself still has some benefits. Another group also wrote a response. This showed up in the Journal of the American Geriatric Society, and this was a group that suggested that goal concordant care, which, if you remember, is the thing that Morrison and colleagues said was what advanced care planning was supposed to accomplish. They said, well, maybe goal concordant care isn't or shouldn't be the purpose of advanced care planning. And in this article, they outlined some additional things for us to be thinking about if we move away from traditional advanced care planning. And one of their suggestions was that perhaps the future of advanced care planning should shift its focus more towards the surrogates, the power of attorney, the person who's identified as the healthcare agent. And maybe we need to be spending more time on thinking about and studying how we choose those people and educate those people and help them execute their responsibilities. And another related angle is an increased emphasis on teaching people about the conversation, about communication with each other, about goals and values and preferences. And that just as we're teaching clinicians to do a better job to inquire about goals, we should be doing the same thing with patients and care partners and the clinicians as well. And lastly, with a nod to research, this author also acknowledges that measuring, if we are going to focus on surrogates and caregivers, that measuring the outcomes that are meaningful to caregivers will also require some additional work on our part, that we need to understand what are the outcomes for care partners that are important. How do we measure complicated things like regret, for instance, when a care partner makes a decision that they're not entirely sure about? And maybe more complicated, how do we secure funding to do research on these kinds of ideas when the outcome may be months, if not years, away from when we actually have the initial conversations? It's hard to get funding agencies to give us money to tell them that, well, we're really not going to know whether this worked or not for maybe 2, 3, 4, 5 years down the road. So this article it didn't suggest that we should throw out advanced care planning, but made some suggestions about future directions in terms of practice and in terms of research. So that's a little bit of background and context to where the conversation has been going in the last 18, 24 months. I think this is a conversation that we've all been reflecting on in our own work. And I hope that we'll have some conversations today about that work and how it's unfolded in the context of this pretty lively critique that's happened in the literature. So I'll stop there, and I'm going to pass it over to my colleague, Erica.
Sure, thank you, Brian. And I'm going to go ahead and share. I have a slide. Brian laid excellent foundation for our talk. And in our past presentation, I focused on, as a clinician researcher, I focused on clinical cases through the lens of a clinician and discussed the influence of COVID-19 on ACP factors. So today I thought I could kind of provide big picture following up on Brian's foundation and share how ACP has progressed kind of in the clinical setting. So the first kind of category is naming. And as Brian shared, and as evidenced through the articles from researchers, there's been an evolution in what we call advanced care planning. And there's been a growth from the static documents that address those hypothetical situations to, naming a healthcare agent, and then also ACP encompassing discussions and portable order forms. since the COVID-19 pandemic, there's been a lot more discussion about what we call in the moment discussions. And that's decision-making with seriously ill patients and their families, engaging with clinicians, talking about goals of care and treatment discussions at the present as they're dealing with their clinical condition. Also, there's a framework of serious illness conversations, and that's a framework for dialogue between clinicians and patients with serious illness, understanding about and honoring what's most important to them. So both of those really are grounded in advanced care planning. Most recently, there's an article that came out in January of 2023, and we're going to share the references about this concept of care planning and the care planning umbrella. Now, with this concept, it spans the life course as people move between healthy and chronic illness, serious illness, and end-of-life care. And this care planning concept really should be tailored to the individual's life course, the decisions that they're facing, and it should be based on their quality of life to the person at that time. The second category I just wanted to talk about is how ACP is being used, and then also access to use. So within usage, I agree with, I actually really enjoyed the article by the late Randy Curtis that Brian shared that was written in JAMA. And as a clinician researcher, he had shared, he spent his entire career developing communication tools. And he showcased the usage of ACP, how it pertained to personal stories and then his own self. So he talked about how ACP was used in his mother-in-law's care to represent her lifelong personal values. He shared how ACP was used in his mother's care while his family was in a time of crisis, and knowing those values helped his family in the future. And then he shared how the story of how ACP has been used in his own care, dealing with his ALS diagnosis. Looking at access, the evolution of ACP has continued to grow the importance of ACP across all care settings. So not just people living in the community, but also in long-term care, skilled nursing facilities, assisted living, and inpatient hospital setting. There's also been a greater uptake of ACP due to technology. Telehealth visits and virtual visits have really allowed for further ACP opportunities, especially in areas that may be under-resourced. And then also there's been a heightened ongoing awareness and recognition of the importance of ACP in underserved, marginalized, and vulnerable populations. And then finally, I just wanted to talk broadly about ACP and measures and outcomes. We talked prior about this goal concordant care, and goal concordant care has really been the gold standard amongst advanced care planning. And a lot of the articles that we're seeing in response to the Sean Morrison article and among leaders in the field are challenging this standard of goal concordant care with the recognition that maybe we don't have the correct measurement due to the lack of validated or standardized measures. I also really was drawn to the Terry Freed article that Brian shared, published in 2022, that talked about giving up on the goal concordant care and then focusing on ACP and caregiver outcomes. And in her article, she actually shares that maybe ACP should be measured by caregiver preparedness for understanding their role and acting in the patient's best interest. And as a practicing clinician, I definitely could relate to that value of how ACP could be measured as a caregiver outcome. A lot of the discussions once someone is in an acute care setting are less focused on them and more focused on their family members and care partners. And then finally, I just wanted to talk a little bit about value and that measurement and how we may look towards what value does ACP bring. I also was drawn back to the Randy Curtis article He showcased and said in that article that the value of the conversation that he had with his mother and family previously, prior to her illness, would not have been captured by traditional outcome measures that we as researchers measure the benefits of ACP. And then most prominent and really touching was how he shared in living with his own illness with ALS, those ACP discussions that he had with his family helped him focus more on joy and gratitude and less on grief and fear. And he really also shared that he was not sure those discussions could be measured with the available outcomes that we use for advanced care planning. So these are the references of those articles that we talked about today. And I'm going to go ahead and stop sharing and move to the next panelist. Thank you.
So we'll turn things over to you, Gloria.
Well, for those of you who had the opportunity to look at our presentation at GSA, what we reported there was a part of a national survey that we had done in Canada early on in the pandemic. And in that survey, we were looking at ways in which people's lives had been changed as a result of the pandemic. And we inserted a couple of questions as part of a larger study that we've been working on for several years that asked people whether they had engaged in advanced care planning discussions before the pandemic, and if they had done so after, based on the supposition that the pandemic may have got people to actually make the move and start thinking about what might happen to them in the case that they couldn't speak for themselves. We were very surprised to find that a relatively small number of people had been stimulated by COVID to get moving on those discussions. And we were particularly interested in marginalized groups in the LGBT community and in the two largest ethnic minorities within Canada, which are Chinese and South Asian. We knew from our lit reviews that these groups, certainly the ethnic groups, traditionally had not engaged in an advanced care planning. So, and one of the big surprises to us was that when we asked those who had started to the discussions, who they'd been discussing with, only 5% of the general respondents, these 4,000 people, had communicated with their doctor, and only 2% within the marginalized groups. So what we have done since that time are a series of interviews with physicians, 3 groups of physicians, one group where 15% or more of their clients were older adults from the Chinese community, and with second group, 15% who had worked with the South Asian community, and then the third were those that worked with the LGBT community. And what our findings are showing is that when much of the research has talked to the patients, but when you talk to the docs, what they start to identify are some of the issues that, in particular, if you're working with Chinese older people, there is the big taboo. You do not talk about death because it's going to bring it on you. And within the South Asian community, our perception is that it's a different situation. It's that they just don't understand the concept. It's not so much the taboo, but rather just getting their head around what is ACP. And so there have been various opportunities and projects that have taken place within the geographical area that I live in British Columbia. In particular, the Center for Palliative Care has engaged in some work in trying to adapt documents and to facilitate community groups to have conversations with these ethnic minorities. The key thing with the LGBT community is that, if anything, they were more involved in and thinking about ACP as a result of during the pandemic. And we think that's because of their previous experience with HIV/AIDS. So that's the thumbnail of our update with respect to our original presentation.
Thank you, Gloria. And now over to Debra.
Yes, hello, everyone, and thank you for coming today. I'm going to turn your attention to some work I've been doing our team has been doing in assisted living on a palliative care education in assisted living random control trial that we conducted. We did a feasibility study recently, intervention for staff, nurses and administrators in assisted living. I'm going to share, it was recently, it was actually done during COVID between 2019 and 2021. So right in the middle of the study that COVID started. So there are some messages and, lessons learned during COVID. Let me just share, if you can see did I share the right thing? Does everyone see the screen? Yes, okay. So it was recently published in the Gerontologist. That's my research team. And it was a study with 118 residents in 10 assisted livings. It was 6 and 6, but during COVID, 2 dropped out and said you cannot enter the assisted living. It was a partnership with the hospice community nurses, 2 large hospice partners organizations, and the training sessions were 4 sessions, 1 a week for 4 weeks. But the main outcome we were trying to improve was advanced care planning discussions and documentation of those in residence charts. And it was tailored to persons with dementia and dementia care providers. And so during the training sessions, the content was specific to how to care for someone who had palliative care needs, persons with dementia at any stage. And we did have, in the treatment compared to control group, a significant increase in those discussions. We started out at pretty low at 13%. It had any discussions or documentation of discussions in the last, we gave a time point of 2 years. And that speaks to what some of the previous panelists were saying, is that these, the ACP is fluid. You have to, what you might have in terms of preferences for care, at one point that could change based on time, change in diagnosis, change in status, healthcare status, change in healthcare surrogate. That was our case. What we found was, in many situations, updates needed to be made because a spouse had died or an adult child had died or could no longer be that healthcare surrogate for that person. A lot of the education was around even knowing the difference of what's a healthcare proxy versus the difference in a healthcare proxy and a healthcare surrogate. And I learned some just from the training was done by the hospice nurses in this study. So the next steps for us is to expand to a larger sample, and then some of what we've talked about here today, and I'll quit sharing there we go. What we've talked about today is I didn't include an outcome related to family, although the conversations were with nurses or administrators and family members of persons with dementia. And when possible, if the resident themselves had some decision-making capacity, and they have, in fact, I made some notes on capacity. If they, could be somewhat involved in engaging in decisions, right? It depends with someone with dementia at what stage. They have a right to be involved in decision-making if they understand the consequence of that decision they're making. One example that I know in the training we give is they may know if they have a headache and if they need an aspirin or if they need some kind of medication, but do they know, because of limited capacity and judgment, would they know if they were signing a DNR, what that really means? What's the consequence of that decision? So that a lot around capacity and engaging in the reasoning about that decision, having the reasoning capability. So next, the follow-up to the next study would be a larger, full sample. I mean, what am I trying to say? Fully powered study, because this one was a feasibility study, smaller sample, and adding family outcomes, which we've talked about here today, are important. And also, I had staff knowledge as the mechanism, and that's not really the mechanism, as I talked and engaged with other researchers, and also the project officer at NIA who's working on the next submission I'm going to do. It's really looking at, it's a whole new field for me, really. I'm not self-efficacy. It's the self-efficacy for staff to engage in these conversations with families. We've talked about that here today too, right? Family, as what Brian had said, and Erica both, that family outcomes are a little more complicated and complex to measure, and you have to measure them for longer. Family satisfaction is one. Family satisfaction with goals of care, and there are some measures. Laura Hansen and her group have been funded on some clinical trials looking at family satisfaction with goals of care communication. So that is an outcome I'm going to consider for this next study. And I'll stop there.
Yeah, Brian, you can take over now in terms of coordinating discussion among the presenters. The only comment I will make as a physician is that physicians and other direct care providers, we were taught a lesson by COVID-19 that the picture in terms of outcomes, it changed dramatically within 2 years. We started with tremendous mortality rates, and then we had the vaccines, which helped a little bit, and then now we have some reasonably effective treatments. So when we discuss issues like that, we have to keep in mind that medicine is moving very fast sometimes, and the decision that was made in the early phases of COVID may not apply today. That's the only thing I have to say, and I turn it over to Brian.
Thank you for that comment, Pan. Appreciate it. So yes, so we're going to spend a couple of minutes just amongst the panelists to see if any of us have a reaction to the other presenters, anything you'd like to raise, add, and then we'll open it to all the participants for Q&A. So I'll invite my fellow panelists to weigh in with any questions or comments on what we've heard so far.
Well, in part of our project, we did focus groups with individuals within the LGBT community. And one of them I remember very clearly saying that she and her partner had done all of the things, they'd prepared all the documents. What they hadn't counted on was that the partner would develop dementia, and therefore was not in the position to be able to do the things that she'd said she'd done. And we've heard that in various contexts. And I think that fits, the people on the ground, when you talk to them, are concerned about these issues. You know, we did it. Now she said, now I have to find somebody and do it all over again.
Yes, and I'll comment to that, similar to what I found in my study. And I had an advanced care planning conference with several providers just on Friday, long-term care providers, hospital nurses, hospice, doctors, nurses, social workers. And that is the case, that you've done everything. And then when it comes time to actually implement or execute those decisions, the person's no longer capable who you had listed, or they're fearful that the person you've listed who at one point has agreed now doesn't want to have the responsibility and the burden to make that decision. In theory, yes, I'll do this for you, but now that it's actually here and we have to make this decision. So it has to be, I think most of us here probably know, it has to be an ongoing conversation. It can't be one and done, and then years from now, this is not going to happen the way you envision it.
But that was also something that our doctors raised. And they were saying that often it's they who have to initiate the conversation. It's not that the patients start out, and that this is not as easy to do, particularly with some of the ethnic minorities.
If I might pick up on the thread of this conversation that you started, Gloria, I'm interested in hearing from the panelists about the extent to which you're aware of efforts to work with people with cognitive impairment, maybe who are in the early stages of dementia, to maximize their participation in the advanced care planning process, recognizing that yes, they may have cognitive impairments, but are there strategies or tools to help them stay engaged in this process for as long as possible, even in the face of their declining cognitive skills? I'm not aware of anything, but that isn't really my area.
I do know in some of the research I've done, and then some of the grants I've submitted, that reviewers always come back and say, you need to include, or it's not clear whether you're trying to include people, and knowing the stage of severity of the person with dementia. Is the conversation just with a healthcare provider and a family member, even though it is about somebody with dementia? So try with that decision-making capacity and staging, because they still have some decision-making capacity at the mild and even moderate stages of dementia. So it can't just be, that's always a question I get, is you say this is for, persons diagnosed with dementia, but you have to talk about at what, stage of dementia.
Yeah, I was kind of thinking of, ways to maximize people's participation and take advantage of what kind of cognitive skills they still have. Are there ways to simplify materials, simplify choices that allow people to be engaged, even recognizing that they may still have some impairments? And maybe that's even true, Gloria, for people working with ethnic minorities who may come from different backgrounds. Are there ways that we should be trying to be more sensitive to where they're coming from in terms of their English language skills or cultural perspective? What kind of adaptations do we need to make to the advanced care planning process?
Yeah, well, what the doctors were saying to us is that you really have to understand the cultures of those individuals and to phrase your information so that it fits and is acceptable. If for example, I work also in the area of elder abuse, and with some ethnic minorities, if you use the term abuse, they don't understand what you're meaning. But if you talk about safety, then you can reach them. But coming back to advanced care planning, I mean, when we've talked with residents of long-term care and with their families, what we hear is that it would have made life so much easier if we had had these discussions with our loved one before they became demented. So, the people on the ground understand that it is helpful, but you just have to give them more of the tools and get them moving on it.
Let me bring another issue that you may want to be able to address, and that is the age issue. From clinical experience, I think that there's more aggressive attitudes towards people in middle ages, let's say up to age 60, 65. After the age 65, there was tremendous diversity, not only based on ethnic or any other minority groups, but also on attitudes which my old main mentor had coined, which is ageism. And it's clear talking to some families that although somebody was extremely functional up to the point that they got COVID, they say, "Oh, what do you expect? I don't want much done because he's 81 or 82." And that you have to educate the family that this is ageism. You have to base it on their functional and value systems. And that's something that physicians in geriatrics, they face almost daily. Any thoughts on that?
I was going to share. I think when you have discussions, especially with older adults, where there might be concern that we're having these discussions because they're in an older population, I think it's providing education that they're, even though they may be, it's mostly how they're functioning and their comorbidities. It's the age is part of the overall kind of situation that they're facing, and then just normalizing that you're having these discussions with people, but we need to do this earlier in the process. If you haven't done it earlier, now's the best time. That's kind of how I approach it, normalizing it, and then really emphasizing, especially their values. Have they changed? Have they continued to maintain who they are as a person? Because that will then play into their medical decisions that they make.
Yeah, well, some of our doctors said that they were reluctant to raise the issue of advanced care planning because that would make their patient give up hope or think that there was something wrong that they hadn't been told about. On the other hand, we interviewed both hospitalists and family practice practitioners, and the consensus of both of those groups is that it's the family doc who really needs to take the initiative, because he or she is the one that is seeing the patient on a continual basis, whereas the hospitalist sees them, in a very short period of time and when they're critical.
I think the new article that came out about the care planning, or the care planning umbrella, that really allows what you're sharing, Gloria, for the practitioner that has an ongoing established relationship with the person to have these discussions all across their life course trajectory, whether they're healthy, whether they're then facing a chronic condition, a serious illness, and then eventually end of life. I think the field should continue to move in that direction, because it allows the normalization of aging, that death, that across someone's life course as they change, that these discussions, their values, their goals are going to change, but we have to start the process of doing it.
And maybe that'll get a little bit more, it got a little bit of a momentum when primary care physicians were allowed to bill for advanced care planning conversations finally. But just because they can bill doesn't mean they know how to do it well. So they're, in addition to paying them for it, we should also make sure that we're training them so they feel like they can have those conversations in an effective way. And the other physician extenders, who maybe more often than not have the time and the ability and the interest to have those conversations. To what extent are we training PAs and NPs to have these conversations as well?
Actually, you made a major point from my experience being within the university. It was a completely different attitude within the university associated practices of physicians and PAs and nurse practitioners, and the ones that they were in the community. They were much less likely to get involved. And also, being in Oklahoma, that most of the time, there was a tremendous difference between the city people and the small community people. I'm not talking, the patients and the families. I'm talking about the practitioners, physicians, nurse practitioners, advanced practice nurses, and PAs. And that is a challenge of how to reach out to those people. And Brian, maybe we should ask even verbally, although it is on chat, for the participants to ask questions or make any comments.
Yeah, that's a great idea. If anybody wants to, I think you can unmute yourself, turn your camera on at this point, throw something in the chat if any of our participants would like to weigh in or ask a question. Heather, welcome.
Hi, I'm calling in from Ottawa, Canada, and I would say represent probably more the clinician side. I'm a knowledge translation specialist situated in a long-term care home that also has a center for excellence. But one of the projects that our clinicians have asked for, both in acute care and long-term care, just as the conversation is saying, is that people arrive in both situations. The client and family, patient and family, aren't prepared to have these conversations in the panic of going to hospital. And now once you're in hospital, it starts a trajectory. So our regional or dementia network, the geriatricians really push for those conversations to happen in the community at a time that's not a crisis, et cetera. So one of the projects I just got involved in, hence why I'm kind of just getting my head around these conversations, but we're looking at what is available for these conversations, goals of care, ACP, and I like what everyone's been talking about, and it's given me some ideas, is like, how does that work for people with dementia? So we have one team of dementia care coaches that work with people newly diagnosed. So what do those conversations look at? Again, along the life course, if our geriatrician had anything to do with it, he would want us to say at moment of diagnosis, tell them that they can't, at one point, you're not going to be able to swallow. And it's like, well, wait a second, people who are newly diagnosed want to be, inspired and have hope. It's like, what does the next 5 years look like? And what is the content of those conversations? And to, bringing up, like, involving the person with, dementia sooner. And then we have the other community team, which is a geriatric psychiatry outreach team, who see people once there are safety and behavior concerns. So those, goals of care and advanced care planning conversations will look a little bit different, the content, but they both sort of work with people over time so they can kind of have that trajectory. So any resources that you're aware of, we'd be happy to kind of introduce, but certainly that's kind of our project for the next year, is actually what everyone's talking about. So I just wanted to add that in.
Yeah.
Thanks, Heather.
I was just going to say, to Heather's point, I have some resources we use in our program, and there's a link to our manual and materials, and I can send that to you, or I'll put my email in the chat here. But we also have a dementia specific living will that our hospice partners use, that you can, it's, at a 5th grade level, it's very, it's made so that you can involve the person at, probably not severe stage dementia, but certainly mild and moderate stage dementia in tandem with the family member.
Deb and Heather, this is a question from my own education. I've read but haven't seen about clauses that you can place in your advanced care planning document that I think are colloquially called Ulysses clauses. in reference to Ulysses, the ancient traveler, that allow a person to say in their advanced care planning document, this is my wish that I'm expressing today. If I change my mind in the future, ignore me. And they put that in there precisely, I think, because of concerns about cognitive impairment and whether a person who has dementia and then appears to change their mind, that doesn't undermine a previously stated preference. Is that do you know how common that is, or is that something that you're thinking about in your work?
I do think, I mean, there's more questions than just, because we've had it both ways where somebody may be named as the healthcare surrogate and they haven't had a conversation with the person at length. So those are the two things you would hope would happen, right? They've not only named you as healthcare surrogate, but they've had the conversation and discussion with you at length of what their preferences are. And so then it would make more sense that you could put that clause in. They could say, yes, we've had these conversations. I know what, and what these conversations we had match what's in writing. So both of those things would need to happen, is my
I'd
thought.
like to ask the panel and also Heather, who has experience with long-term care. One of the problems we faced with early dementia patients in nursing homes in the early phases of COVID was when we restricted them to their rooms, two things happened. Either they had a significant decline by lack of interaction with others, and the second thing that happened, some of them, they had aggressive behavior, they were leaving the room, and then as a doctor, I was asked, do we restrain them or not? And if you restrain them, as all of you know, it's going to be a disaster. So everybody has an idea how, even in the presence of advanced care planning, which said otherwise, how do we address those issues in situations like that? Any one of you, the technicians, Heather, Erica, any ideas?
Well, what we're seeing, this isn't answering your question, but like we're seeing in acute care, restraint use, and in our long-term care it's off the chart. It's off the chart, and we've never seen these rates like we've seen before. Like running out of restraints in acute care, they've never seen that. Our rate in the long-term care is double. So I don't, yeah, I mean, I guess there's lots of reasons, but I'm just probably on both sides, perhaps increase agitation on the one hand, decrease capacity on the other hand for clinicians around different time bandwidths, et cetera. Like they're just not letting people even walk. So we have, my research is on risk, and people are not wanting to have patients, clients, residents walk around because fear of falling. So I don't know, it's probably another topic, but we're seeing that really increased use of restraints.
Some of that, if the excuse is that they're short-staffed, and or during COVID that they had to restrict patients so that they weren't getting infected from other patients. But that's part of the long-term care reform that we can't let fall off the radar. Because we were moving, certainly in Canada, we're moving in the direction of minimizing restraint use.
Well,
So-
when I meant restraints, we didn't mean physical, handcuff type restraints. But what some people were advocating is to say, to put locks in the doors. The patient will be able to move within their room, but not go to another patient's room in the face of out of control infections in certain areas like the big cities. So that's where there's a big discussion, and lawyers were involved, and ethicists were involved, and we never arrived at a meaningful solution. Any ideas?
I think it's definitely a loaded issue. You know, there's the autonomy of a patient and the beneficence of looking out for others. And it makes me think about the importance of having discussions about benefits of burdens, and also making sure caregivers of these patients or these residents are really aware of the severity of what's going on. You know, you're trying to prevent infection, but that also then will contribute to their social isolation, their likelihood of their dementia trajectory getting worse, and having open and honest discussions about expectations moving forward. I don't have the answers on that one.
Anyone else who joined us today for the session have a question or a comment?
Well, anyone from the panel that would like to ask each other any questions?
I have one for Gloria, and it felt like, or anybody can weigh in, of course, but it felt like there was something that went on during the pandemic that did motivate some people to pursue advanced care planning, and maybe they wouldn't have done it if they hadn't seen what was going on around and how important it was to talk about their preferences and wishes, so they didn't get intubated or something, for example. Is there anything that we learned from the pandemic about what motivates people to pursue advanced care planning that we could use to continue that motivation?
Well, I think people need to understand that we're in a period in history where we're going to see more disasters. Whether we're, that's the third area I work in, that there are natural disasters, weather-wise and so on, and that we really do need to think about who is going to speak for us if we can't speak for ourselves in any of those situations. And so to paint that picture. And also, I think what came through very clear to us, particularly from people in the LGBT community that we spoke with, was that they had thought through of who's going to be there for me, and recognized, they couldn't just fall back on the usual, well, it'll be my mother, my brother, my uncle, some blood relative, but rather who were their families of choice, and would they, in fact, want that person to look after them? It's one thing to say, to help me, to drive me to the doctor and so on when I'm relatively well. It's another to ask somebody to do personal care. And certainly what we heard is that, it's very important who you choose to be your surrogate or your care provider.
Brian, we have only less than 2 minutes. Any closing comments as the chair of this nice session?
Well, I'll defer to Deb. Deb, did you have another comment you wanted to throw in?
No, I was actually going to say that I have a meeting at 1 and I don't want to just cut ties with the group, but this was a very informative for me, and I do want to get the slides both yourself and Erica shared today. They're very helpful. I was trying to take notes because those two issues you hear, there's the two different debates and camps, but you both really laid the issues out very clearly and with the references. So
thanks for joining us, Deb, if you need to leave.
Yeah, thanks for including me on this.
And we also just draw people's attention to the fact that there are a number of tools out there to help getting the discussion started.
Yes.
There are, in our particular project, the broader project, we reviewed a number of them and came up with a small number that are evidence-based. And so, that's—
Please share that. Yeah, please share the result if it's in a publication or just, whatever you have.
Thank you. We're moving towards the end of our time. Thank all the presenters, all the participants, especially Brian, who was the chair of this big effort. We want to let you know that this is recorded and will be available at the GSA website. And again, thank you everyone. And this is the end of this program. And Judy, thank you again, and you can shut it down.